Today we received a patient, 3-year-old child with a history of airway foreign body in the left main bronchus. As you can see on the imaging, this patient has left hyperinflation and left lower lobe consolidation changes. As I did a diagnostic bronchoscopy, this patient had failed bronchoscopic attempts before and then referred for removal. I am using a 4 millimeter bronchoscope to do a quick diagnostic bronch, and then I'm able to visualize the foreign body. What you also have to notice that the foreign body is stuck at the distal left main, causing occlusion of both the upper lobe and the lower lobe, and also the mucosa at that point is not very healthy. Initial attempts, being a child, we tried pushing a basket because that has got a better grip. But the problem here was like when we tried to put the basket, the space around the foreign body was not so good. So the foreign body is like not able to grasp into the, we're not able to grasp into the basket. And then the other options what we have is pushing a distal balloon and then try to, so we need to follow two steps in these kind of foreign bodies. One is to dislodge the foreign body into the proximal airway, and then use the different tool if needed. So the next option is like we thought of using a 1.1 millimeter cryoprobe. So to use a cryoprobe in these small airways, again the challenges are like the mucosa is so close. Sometimes you freeze the mucosa and then cause more bleed. So we have to be very careful when you use cryo to extract foreign bodies in pediatric airways, making sure the cryo gets adhered to the foreign body, not to the airway wall. But a 1.1 cryoprobe for some reason was not able to get attached to the object, and then I tried using a Fogarty balloon just to dislodge the foreign body into the proximal bronchus, but again I was not finding space to this is a very good technique to dislodge the impacted foreign bodies, but in some cases you may not succeed. Like in this case, when I was trying to push the balloon distally, the foreign body was so occluded, but I was successful in just making the foreign body become more flat. Like you can see here, I was able to change the position of the foreign body using the balloon, and then keeping that position, then I thought of using a 1.7 millimeter cryoprobe to dislodge the foreign body into the main bronchus. So again, as I told you, like when you use cryo in these smaller airways, make sure like your angle at which your instrument comes stays away from the mucosa. So carefully I just try to push the cryoprobe onto the surface of the foreign body, and this time I was successful in getting it. But again, as anticipated, the problem with cryo in these cases is like the subglottic space in these pediatric airways is too narrow, and then they come till the subglottic space and then get dislodged. The main problem is the foreign body going on to the right side, as you can see in this case, because desaturation happens very quickly if if a foreign body which is on the left side and then that goes into the right and then cause an acute airway obstruction. So you have to be very quick in extracting these kind of foreign bodies, and what I'm trying to do is without taking any chance, this time I use a foreign body extraction basket and then loop around the basket. The vision is a bit disturbed still, but we have to be quick in performing the procedure. So I just ask my assistant to close, and then we get the foreign body out of the airway, which turns out to be a betel nut in this case. And when I run a quick bronchoscopy after removal of the foreign body, you can see the mucosal changes that happened and some loose granulation like tissue there. And using a 1.1 millimeter cryoprobe, I just quickly remove the granulation tissue. Being an organic foreign body, this type of intense inflammation and mucosal changes are very common, especially with organic foreign bodies. And there is also a little small flop there. And then I'm using a 1.1 cryoprobe, and then taking advantage of the 360-degree freeze there, just quickly come out, and then you can see the patent airway. And then when we run a quick bronch following the procedure to see if there is any dislodged fragments, we did not find any of these, and the airway remained patent. So the post-operative, since he has post-obstructive pneumonic changes, we treat them for a week with antibiotics, and then that should be okay.